Thank you all for joining us this morning for this important discussion. So there's been a growing focus on the use of AI in healthcare, and more so now as the use of technology becomes a mainstay of how we tackle health crises. And the dilemmas that form the backdrop of this panel range from patient privacy and consent to legal culpability on AI enabled decision making. The core question we want to answer is, are we ready in terms of regulation to tackle the challenges that will come with AI in public health? I will hand over to Christina Rao, who will be the moderator for this session. Christina.
Thank you, Trisha, for the very helpful introduction. I am Christina. I'm representing the International Innovation Corps, which is a program with the University of Chicago Trust. And I work with the Health Ministry, where we're helping the digital health team think through how emerging tech, specifically AI, can be applied to the public health context. I'll be moderating the session and taking the liberty with speaking a little bit in the beginning and then handing over to the panelists later. A little bit more of a context setting on our topic for today. The discussion around AI in healthcare is not novel. It's predicted that the application in healthcare in India will reach more than 430 billion rupees very quickly. It has immense potential from nudges in lifestyle mobile applications to also supporting clinical decisions in hospital settings. If it does deliver on its potential, AI can respond to public health challenges in a responsive and cost-effective way and bring India as a country closer to attaining its goals against SDG 3, which is good health and well-being. But despite its promise and potential, AI-based technology has also been a subject of concern. Discrimination and bias against specific social groups, being counterintuitive to clinicians when used in a clinical decision support system, or even the lack of explainability, which means not understanding how an AI got to where it did, and the model not being able to explain so, are some of these concerns. So naturally, it's a challenge to regulate and to put a fence around what is permissive in the realm of AI and what is not, especially when it's applied to public health context. So we're going to use this panel to address some of these questions. And joining me are three stellar individuals who I'm going to take a moment to introduce. Dr. Anurag Agarwal is an Indian pulmonologist, medical researcher, and the director of IGIB, which is a CSIR institution. He's also co-chair of the Governing Health Futures Commission, which explores the convergence of emerging health tech with universal healthcare coverage to support the attainment of SDG 3. R. Chandrasekhar is the Deputy Drugs Controller at CDSCO, which is Central Drug Standard Control Organization, India's prime body for regulating drugs in India, including medical devices. He looks into biologicals, including vaccines, drug legislation, and legal liability and IPR issues, among other subjects. Sheetal Ranganathan is a biomedical researcher and a business leader with a career spanning over almost 2 decades. And she's currently leading in 2 different capacities. She's the head of global operations and of digital innovation at ValueServe. Ms. Ranganathan is also an advisor to the National Health Authority of India. To begin the discussion today, I would like to now pass the baton to the panelists, and I would like for them to respond to our opening question, which is, what is the biggest challenge for regulation of AI to address in healthcare, specifically in making its application successful to public health? If I could ask Dr. Agarwal to lead the answer.
Sure, Christina. Thank you very much for a very nice start and introduction. I think the challenge for all regulation tends to be how to be lean and balanced at the same time. And we are seeing it, I guess, to the most extreme possibility right now with the pandemic. You need to be lean so things come out fast. You need to be balanced to protect the interests of everybody from the companies to the stakeholders, to the people whose data it is, to the general public. So yeah, striking that perfect balance between leanness, efficiency, and yet being balanced between the ultimate needs of people with a long-term view is the biggest challenge. That's how I see it. I'll end there.
Thank you. Yes. Thank you, Sheetal. Can you carry forward and give us your opinion?
Yeah, sure. Before I speak of challenges, and I'm sure we're going to delve deeper into these challenges, both at the product level or the human use level or the systemic level, I'd like to state my position on the overarching principle that I believe should drive the AI/ML regulation discourse globally, which is that we must act like one world and agree on a common philosophy and then write rules in collaboration, in unison, to keep a responsible oversight on this wonderful yet very complex new world technology for health. And I say this for two reasons. Any nation's health is no longer an internal matter, and COVID has been a brutal reminder of that for us. On health matters, at least, working in isolation for commercial or geopolitical advantage or to drive trade and diplomacy is simply unacceptable. We cannot allow future pandemics and public health accidents to reel us into another kind of an existential crisis of such intensity that we are in right now. And two, cool innovations or technology anyways develop precocious wings, and they cross borders before we even know, especially the ones that add significant value or convenience to life. And in the case of health tech, we're speaking of safeguarding human lives. And what's more valuable than that? So if tech is transferable across borders, rules and regulations governing it should also be.
Thank you, Sheetal. Mr. Chandrasekhar? Mr. Chandrasekhar,
Chandra, you're
could
on
you
mute.
unmute yourself?
Yeah, sorry. At the outset, I would like to thank Krishna International Innovation Corps for creating this opportunity, and then try to meet various persons from AI background. So the major challenge as far as the regulation is concerned is that, so from no regulation, so we are going to the extreme end of fully regulated. Okay, this is the greatest challenge that I foresee, because neither the AI developers or the tool manufacturers or neither the regulator, so both do not have any experience in the regulation. So this is the journey that we need to travel together. So that is point number one. Number two is that, so we are not far behind in the sense, so the entire AI regulation in as a medical device, and also AI regulation in public health, in both these areas. So internationally, the regulation is evolving. Unlike drugs and other classes of medical devices, there's no set point. You don't have a benchmark to say that we need to reach to this point. So we have a great opportunity in the sense that we have an opportunity to create a benchmark. So WHO also has created several working groups. So they have created a focus group for development of regulations for use of artificial intelligence in health. So I'm also a member of one of the working groups in the regulatory working group. When I understand the status of regulation in other countries, they might be one step ahead in the sense they have already started implementing, but the regulation itself, they have not emerged. So because in 2017, we have started this new medical device rules, and we have implemented from 2018 January onwards. So we have followed the international status and the international criteria for which medical devices are regulated, and we are at par with other countries as far as general medical device regulation is concerned. And the same will be applied for AI tools also. So we will discuss it in further interactions. Thank you, Krishna.
Great, thank you. Thank you for covering a breadth of issue areas that are yet to come up. For our audience, just a housekeeping note. We are going to continue this moderated discussion where I pose questions to the panelists till about 12:15. And from 12:15 to 12:30, we can address questions from the audience. So if you have questions that come up during the moderated discussion, please feel free to put it down in the chat box, and we'll be picking these up towards the end of the session. Going back to the moderated discussion, I have a question across me, but my first question goes to Mr. Chandrasekhar. We've spoken a little bit about the need to be lean and be judicious in our approach with regulation. What is the regulator view on balancing patient safety and promoting innovation for high-stakes clinical solutions that include AI?
Yeah, good question, Christina. Thank you very much for asking this question. As far as the patient safety is concerned, so it is given the utmost importance. The philosophy of the CDSCO, because I will take an analogy with respect to the clinical development or clinical trials that we permit for introduction of new drugs or clinical investigation for approval of medical devices. In both these cases, so patient safety is given the utmost importance. But at the same time, so we need to balance and enable the innovation so that new products continue to come into the system and give benefits for the patients. So as far as the devices or software as a medical device is concerned, we have categorized the medical devices or even this software as a medical device also, that they are categorized into 4 categories. So class A, class B, class C, and class D. So these are in the order of their risk analysis. So class A is the lowest risk and class D is of the highest risk. So internationally, the same principle is being followed, the risk-based analysis of devices as well as AI tools also. The regulation will be the stringent as far as the class D is concerned, and is the less stringent as the stringency reduces as you go from class D to class A. And in case of the data required, clinical investigation data that is required for approval of any medical device or AI tool is concerned. So it will be less required in case of class A, or may not be required also, because we have given provisions under medical device rules, which says that it can be, I mean, the regulator has to justify why we should ask for a clinical investigation data.
Yeah.
So normally it is otherwise that it is mandatory for the applicant to submit the clinical investigation data for approval for class D. But in case of class A, the regulator himself has to justify why he should seek data.
Right.
And in case of other, say other classes also, if the device or software as a medical device is already approved in other countries, so in those, then the regulator has power to defer or omit or reduce the requirements of. So these are some measures that have been already in place. And as I said before, so we are evolving. So we will look into that, how much we can reduce, or maybe we need more. We don't know. That we will see in the times to come.
Yeah.
Thank you.
Thank you. And that's fair. We can maybe discuss the touch points of what manufacturers would need to prove and what they would need to provide as evidence to prove that balance between safety and efficacy. Dr. Agrawal, I wanted to get in your thoughts here. There's been a lot of concerns that captured even from the clinician perspective on what AI would mean, not only with respect to the workforce, but also how it integrates well with clinician decision support systems. Can you give us some input on what perspective would need to be integrated when we're thinking about regulating AI from the clinical point of view?
Sure. Before I answer, let me give something that could be called either a better perspective or a conflict. I'm married to a radiologist, and AI probably has entered the field of radiology more than anything else. So these discussions about AI replacing radiologists getting out of a job within a few years, have been like routine. What I'll tell you the end first before I justify why I say the end is. Doctors who know how to use AI will replace doctors who do not know how to use AI. But I do not think AI will replace doctors anytime soon. So I'm putting the cart before the horse. Now let me tell you why I go there. Even in something as digital as radiology, where you have minimum human contact and where you have almost no such things like the healing touch being provided to anybody, bringing a human component to it. When you look at what current AI is capable of doing, and I must emphasize everything I'm saying is about AI where it is at currently, is very different from what you're actually asked to do. You are never asked, is this only this disease or only that disease? It's never a dichotomous choice. It is never a list of 5 things from which you have to pick. Very often you get open-ended questions, which include a wide number of possibilities, and no current system is trained on every possibility. That's only human experience so far. So where humans have an advantage is the search space in which you are supposed to look before you start going into a classification mode is very much contingent upon context and experience. And context varies greatly from country to country, setting to setting, patient to patient. That is far more complicated than simple image classification recognition. And that's where I think humans will continue to have a large advantage for the foreseeable futures. What I will only say to this is that physicians, whether in radiology or pathology or pure image specialty, but who think like physicians, as opposed to simple tools to classify things and say yes and no, are in no danger anytime soon. But people who are acting only as classification, yes, they will face some degree of competition. In the end, for the foreseeable future, the last reason, somebody has to take responsibility for the decision and the medical legal implications. I don't see that AI will reach much beyond decision support for human medical doctors in anything except severe emergencies, as we saw in Wuhan, for example. I'll end there for now.
Thank you, Dr. Agarwal. That's a very useful perspective as we move ahead, because so far we've been discussing AI as a broad umbrella, but there's a big difference between AI that includes a doctor being in the loop versus being kept on the loop. And as we progress, hopefully the discussion can address both kinds of use cases.
Sure.
Sheetal, if I can bring you in here. There's been a lot of innovation that's happening to address the use of AI in healthcare largely. Speaking in the context of public health, what role do you think innovation has in this ecosystem? There's been some speculation around how AI, the industry innovation tends to favor innovating for only like specialized medical tasks, say disease prognosis in tertiary care centers. Do you think innovators and industry players can find their way to also innovating for the primary health context, which might be closer to the front line, closer to your A&Ms and other frontline health workers?
Right. Thank you for the question, Christina. You know, before I get into the aspect of primary care versus specialty and tertiary care, you know, I think what I want to bring to the fore is that there is a tremendous activity as far as health tech innovation is concerned. And just 2 data points to that. But before that, you know, as Chandra pointed it out, we are moving from no regulation to some regulation to probably more, you know, very heavy regulation. But it is this lag period, you know, between the pace of innovation and policy, when creativity is generally the most prolific to become disruptive and transformative. So right now, AI and ML based health tech is exactly in this gray zone, which is why we are having this discussion while the inventors are busy inventing. So, you know, for example, in the US, funding in digital health in just 2018 was about $15 billion. That's staggering. And if you just look at this year, in the first quarter of 2020, which is the pre-COVID months, it was already $3 billion of venture funding that went into digital health. And in my own experience of working with the Bright team at the NHA of India, you know, we figured that 70 to 80% of health startups that are coming up are actually working on digital health. Now coming to primary care versus tertiary care. So I don't fully agree, Christina, with the presumption because primary care is by far the largest addressable market and with maximum unmet need to meet the crucial last mile challenge of access. Which means there's a huge commercial impetus also for the opportunity that the industry must jump at. There's an equally huge impetus for governments to frame or reframe the ecosystem to facilitate our innovators, to realize the vision of health for all as one of the prime SDGs. So AI-based smart tools actually can be of immense help to maximize health outcomes and efficiency within limited resources, especially the connected and cognitive devices such as portable sensors or wearables or apps which offer continuous real-time monitoring and AI-enabled point-of-care diagnosis tools or aids. So, first, in the primary care setting, they will enable patients to participate in managing their own health better and to engage better with both caregivers and doctors. And secondly, they will allow primary care physicians to deliver first-line therapies almost autonomously, allowing them to capture, for example, longitudinal data on disease prognosis and outcomes, as well as patient experience, and sketch valuable case histories for referrals to the specialists. So the goal of AI-based products in the primary care settings is actually to help primary care providers, and I'm chiming in with Dr. Agarwal here, so that they get help in rapidly diagnosing the condition without extensive testing, especially for specialties which are predominantly ambulatory care driven, such as dermatology or mental health, where AI-enabled chatbot technologies or computer vision-based technologies can be of great value. And also for chronic diseases management, where after a specialist advice, people may go to the primary care physician too, to ensure, that everything is on track. So enough evidence exists where apps have proven to have positive impact, for example, on diet or activity monitoring or adherence to medication or, giving behavioral nudges, particularly for cardiovascular diseases or Parkinson's or multiple sclerosis, for example. So really, I think all actors in the health ecosystem have to get together to ensure that more innovations are brought to the market in the primary care settings, where obviously governments can help a lot to refocus, for example, on the digital health mission objectives in India. In the current version, the focus is on laying down the infrastructure and foundation, mainly for back office tasks, such as information flows or to manage staffing and logistics. But we need a parallel focus on products and solutions for the frontline health workers. And also there's an important condition, precondition to this, which is to promote speedy mobile penetration and internet connectivity. So it's a pity that such a useful and timely app such as Arogya Setu, which we have been, promoting a lot, it cannot be used by 50% of our population because they don't have smartphones. So there are these infrastructural preconditions that have to be met so that more and more products are brought into the primary care setting.
I agree with the preconditions to innovation. I think it's very important to address the data problem and how we're relying on a very healthy data ecosystem to conduct innovation. But in many ways, the infrastructure and the ecosystem that comes before innovating is failing the innovators themselves. And there's been workarounds. There are organizations and companies that can collect their own data repositories and build over that, and have a proof of concept that then gets scaled to a public health context. There's also been a lot of government thinking on building the NHS, the National Health Stack, the NDHB, which is laying down building blocks on how you look at bringing emerging technology closer to public health data repositories. What do you think is the innovation sentiment around what the government can do or what a regulator should look into with respect to these infrastructure pieces? What needs to be sort of smoothened out before we can even think of innovation?
Certainly, as I pointed out, infrastructure, etc., and more than that, one has to bring a lot of speedy reforms on, for example, health insurance rules and data privacy rules, of course. There is a huge push towards primary health infrastructure and staffing now, given the COVID shock. And one can also learn from the limited failures and successes of health agencies in other countries who are slightly ahead of the curve in going digital. So, for example, in the UK, NHS, it has faced somewhat data privacy issues in its collaboration with the private sector, or the FDA in the US or South Korea. So I think the world is still learning, but if there were to be certain basic principles, to frame the rules and regulations around it, then I would say, if you divide it at 3 levels. So first of all, at the product level, obviously, and Chandra would agree, the single most important requirement is to have standards to ensure that there is enough evidence through clinical validation on how safe and accurate and reliable an AI-based product is. Also, how smart is it on exceptional handling? Because these are the factors that will determine the doctor's confidence in accepting these products. If only they enable sharper clinical decisions or save time or improve the patient's quality of life, will these products be valued by the doctors? Then at the human use level, which is for the patient, again, regulation must give the right to ask for consent when we are talking about data. Whether one exercises this consent is based on the persona, whether a person is a privacy maximalist or a balancer. But the decision generally will be based on a fine balance of 3 factors, value, trust, and interest in public interest. So if the tech is truly stacking up, for example, my odds against a stroke or a respiratory distress, it is certainly valuable enough for me to trust my life with it. Plus, if I'm getting a bang for my buck, spent on health, then probably I may be more open to consider whether I'm okay or not okay sharing my health data in return for an early warning signal for my health that could save or prolong my life, or for a larger good of humanity, whatever really motivates me more. So at the end of the day, as far as the consent is asked, I think the data privacy rules have to be framed around that. Then at the system level, policy design principles have to be framed in a way that they enable truly useful use cases after thorough due diligence and cost benefit analysis. Ones that really bring operational and cost efficiency in the health system, and not just because they look very cool or they are intellectually, advanced ahead. So we have to look at systems, and this will be country specific decisions, that we bring in those products and solutions that improve access for the medically disadvantaged, the poor or the uninsured or medically frail elderly population. And finally, also those who increase inclusivity. We have to connect the digitally illiterate to our care systems and not really widen the digital divide further.
Thank you, Sheetal. Very important points that you brought up with respect to getting AI further integrated in the public health context and acknowledging systemic challenges that exist even before we discuss regulation. I'm going to pose a question to Mr. Chandrasekhar about how a regulator would consider responding to these systemic challenges. We know that the CDSCO is the country's regulatory authority on drugs and pharmaceuticals, and the pharmaceutical industry has been thriving under its regulatory scope. India is now the largest exporter of generics worldwide. Medical devices have now been recognized, and as of April 2020, software as a medical device has also been recognized. But this is quite a radical shift in a regulator thinking about certifying for deployment a specific technology versus looking at AI algorithms that learn on a continuous basis from the inputs that it gets by working on field and being deployed in field. So what does it mean for a regulator to respond to this change in its structure and possible function? And how does CDSCO plan on responding to it?
Yeah, thank you, Christina. So, the question posed by you is the greatest challenge that we face today. Uh, so, if you see the major challenges that we see today, as Sheetal rightly said, is lack of standards to assess the safety, effectiveness, and performance of these medical devices or software as a medical device in particular. So, for at least a product, several standards have been laid down in India by BAS, by ourselves, or by internationally by IMDRF, where other regulatory agencies. But AI, for that matter, so not many standards are available internationally also. So that is why we have to work closely with other agencies, how the standards need to be set, and then how to keep on improving upon the standards as the ecosystem evolves. But the greatest challenge is that the manufacturing of, if I can say manufacturing, the manufacturing of AI tools is at a tremendous pace, rapid pace. The regulators are not in a position to catch up with the pace of the evolution of the AI tools. That is one thing. The second thing is the data. Sheetal also has rightly said that the access to data, that is the biggest challenge. So we don't have, at present, we don't have an, say, a policy or ecosystem or regulation on how to access this data. At present, I don't know how the AI tool developers are accessing this data. So they are generally tied up with some of the hospitals, and they are using the patient data. For there lies the biggest challenge of the privacy and security of the patient data. So as you also know, so you also have been a part of the team in Health Ministry. So the Health Ministry has constituted the task force to address these issues. So the major challenge of this task force would be how we address this the data access of the patient data access, and then make the data available for the AI tool developers. So the sooner, the quicker we address, we lay down the policy, the faster the growth of the AI tool, the industry in our country. So there are other issues with respect to the data security, data integrity, and then there is a issue regarding real world evidence to assess the performance of the AI systems. So if we need to benchmark them, if we need to validate them, so we need to have the real world evidence. So who will get the real world evidence, and then how to use them for validation purpose, whether it is the role of only the developer or it is the responsibility of the regulator as well. So these are the challenges that we need to address very quickly. So by the time that the regulation starts, say the regulation has started in principle, but once it starts implemented, maybe 18 months from April last month. So we should be ready with all these questions. So I would not specifically say that this would be the pathway or this would not be the pathway. So I would leave for the task force, for the ministry to address these issues, keeping my fingers crossed, so that so as to say that I have an open mind to for every every sort of solution. Thank you, Vishnu.
That's reassuring. So the hope is for inputs from this session also to inform the work that the ministry is doing as well as the CDSCO. And in order to maximize that opportunity, I'm going to ask Dr. Agrawal to take us through the most sticky areas of what it would mean to regulate and think about balancing privacy with higher accuracy tools that might be deployed in public health. I want to specifically touch upon the area of explainability, which comes to the forefront when we are discussing leveraging AI for the front line and allowing previously, so to say, relatively digitally illiterate frontline health workers to now adopting simplistic and then AI-based technologies to perform the tasks that they would otherwise do. So can you take us through what is explainable AI and shed some light on how research can guide a regulator's perspective on striking the right balance with respect to explainable AI?
Explainable AI is where we know roughly, not never perfectly, why the AI tool made the decision that it did and the fundamental reasons behind it. And let me tell you why it's important before I tell you how we are moving towards it. Imagine a very simple question of whether the X-ray has a pneumothorax. Pneumothorax is a case where the lung drops, right? And you build an AI tool that is 95% accurate at seeing where the lung has dropped and air has come inside the cavity. This is a potentially life-threatening problem. And if you don't intervene early, you can have the patient die. There is an actual example of an algorithm that worked wonderfully in picking up pneumothoraxes. But when we tried to figure out what is the computer seeing, we found it was identifying the tube placed in the chest to take the air out. So tubes are placed after the pneumothorax to take the air out, and then X-rays are done again. And then until the patient recovers, the tube remains in the chest. So when the algorithm was given lots of X-rays with pneumothorax and without pneumothorax, it being a computer and not a human, simply found that if you see a tube inside the chest, the patient has a pneumothorax. Now that would be an absolutely useless algorithm for this, because after the tube is in, all of us know it has a pneumothorax. What we really wanted the algorithm to do is to find out the patient has a pneumothorax before the chest tube went in. If we did not know that the algorithm was looking at the tube, you could go there, take this into practice. It could even work on a nice set. If nobody was careful about putting enough number of X-rays, one might say 95%. So current level of explainability is we do something called activation maps. It highlights the pixels on an image. If you remove them, the performance of the algorithm would go down. And that is the first level of explainability on visual type of AI systems, which are purely image classification, classically called CNNs. So now every CNN must develop activation maps highlighting the area of the image that they believe is contributing to the result. And a doctor must agree that what they are seeing is relevant from a mechanistic standpoint. And that's the first level. The next level is far more complicated. Next level is making predictions. It's not about an image anymore. You're trying to say which ICU patient is about to crash. And you might be looking at hundreds of parameters. And sometimes you might be looking at things which are not quantifiable in words at all. You might be finding parameters and patterns within ECGs that the human eye simply cannot see or appreciate. Now, even if it explains, the human is incapable of understanding. So explainability of this AI is simply about, can you at least figure out, is it looking at a particular set of features within an ECG? And some human says there is a plausibility to these features being potentially informative, but we cannot necessarily always make sense of them. And I have no idea how Chandra will deal with these problems when they come to him, but they're not going to be trivial at all. And before I end, I will just give one last example of how a bias, no matter what you do to eliminate, to increase interpretability, cannot go away. In the US healthcare system, they use an AI algorithm to predict which patient is going to get worse, to give them additional care early. Now it realized that for the same degree of illness, a Black person was less likely to get that additional care compared to a white person. No human was involved in the decision making. It could not have been a racial bias on the part of the AI system. It turned out to be something very simple. How do you know that patients got worse? What is the proxy measure? The proxy measure was expenditure. So people who underwent high levels of healthcare expenditure were thought to have got worse. And obviously people who did not undergo high level expenditure, poor people, were thought to have not got worse. So one must be very careful in explainability. It's not always about the AI. Here, some human designed the study, some human provide the proxy marker of what constitutes worsening of illness, and they chose to use a economic marker as opposed to a medical marker. So explainability will run multiple levels. Explainability of the AI tools, explainability of the data provided into the tools, and explainability from the point of view of the people who designed the entire study. Unless you bring all these three things together, people at CDSCO will have a very tough job trying to figure out if the algorithms actually do what they're intended to do beyond simple classification. Sorry if that was a little bit long-winded.
No, it's very useful. Thank you for using examples that we could also understand and distinguish between. It's helped really drive home the point. I'm using this now as a chance to pivot into our audience questions. And there's a very relevant question that's come up as a follow-up to what you were saying, Dr. Agrawal, about not knowing where to draw the line and how the line is subjective to the context. Do you think that the Indian ecosystem is ready perhaps for AI sandboxes to be set up in research hospitals to explore this line?
I absolutely think it is. Let me borrow something from quantum computing. There are three words: quantum usefulness, quantum advantage, and quantum supremacy. Usefulness is simply about usefulness. It might do it a bit faster, it might do a little bit cheaper or better. Advantage is about it truly has an advantage over any other means of computing. And supremacy is, like cracking 64-digit encryption algorithms. Nothing else can do it, only a quantum computer can. Now in the AI world, these are the three cases as well. Now, if you want to do a simple chest X-ray detection for tuberculosis, it has tremendous usefulness in an area that has not seen a radiologist for the last decade. There are plenty of aspirational districts where thousands of X-rays are sitting unread. Even if you can find an X-ray that disposes of even 50% of the cases with accuracy and marks 50% for a human observer, it is useful. And I think the regulator would need to look at it very differently. And Sheetal mentioned it so correctly in the beginning that primary care is probably in countries like India where the maximum impact would come. But context is key. This would be completely irrelevant, for example, in Sweden. The next level of true advantage, for example, I can give you the wrist fractures. Now in wrist fractures, in AI will almost always be better than a human radiologist. Wonderful decision support tool. Supremacy would be in trying to predict cancer or working through massive amounts of genomic data. The human mind can't even begin to comprehend looking at 3.5 billion bases to find out which person has a possible genetic disorder. For each of these three, you would use different regulatory standards from my point of view. Use case scenario would have to be built in. Potential for harm would need to be considered. And the degree of supervision or autonomy would need to be considered. And again, the real answer would be given by the true regulator. And to do all of this, these sandboxes where people can play, work with the regulator, figure out the optimal strategies would be required, especially in India, where there are lots of unmet public health needs. If you prevent the AI algorithms from coming in, they will simply remain unmet.
Thank you, Dr. Agrawal. Responding to a question from the audience for Sheetal, there's a question that asks, is there a legal framework if I am a vendor who wants to sell the healthcare data to other companies to build AI?
Well, ideally, the question should be directed to Chandra, because at least as far as I know, no, there isn't. And that is the situation that we have at the moment, that nothing exists. And what data are we talking about? What do you consider as health data? Even that's a question. So, for example, health data is just not what my pathology results are throwing up, or the data that is collected through my diagnosis, if at all my health record is electronic, that is, or what kind of medications I'm consuming. The health data is also a lot related to my social behavior these days. I'm not talking about the health expenditure data, as Dr. Agrawal was speaking of, but when I say social behavior, it could be how much I am exercising, or what kind of food I'm ordering on the regular platforms that we order food from. If I'm having a pizza almost every week, obviously that doesn't bode too well for my health, given that a person knows the profile of my age or propensity to various diseases, etc. So at this point in time, really nothing exists, and that is really the problem at hand to be solved. And the sooner we solve it, the better it is, because clarity is important, not just for regulators, but absolutely for the industry. To decide what kind of products to, not to decide what kind of products to build, but what to be aware of, and be careful about when they are using data and privacy issues are involved.
From a
Mr.
practical
Chandrasekhar.
standpoint, data is already being sold. We all know that.
Yes.
Yes.
Now, regulatory standpoint, Chandra can probably answer best.
Yeah.
But the Indian Disha Act, which has not yet become law, as far as I know, has the concept of healthcare exchanges. But until one is set up, I have no idea how it's going to be. So maybe Chandra can.
On that note, Mr. Chandrasekhar, could you merge this with an audience question, which asks, what is the enabling regulatory framework when it comes to data and AI? And when can we see some framework which will come into effect?
Actually, as I said before, so this is the data exchange is the greatest challenge. But I would say that that does not pertain to the regulator as such. So it is for the government to provide policy. So how to access patient data, so how it can be exchanged, how any AI tool developer can access this data. So that is for the government to decide. See, for example, even today, if it has been a drug, if it has been a conventional medical device, so if someone is coming to us, we ask them to generate data. So we don't say that, so you go there, you get the data, and then you validate it, all those things. We don't say that. So it is to the developer to access this data or generate this data and then come to us with results, okay, with the claims of the device or SAMD, software as a medical device. So it is for the government to create an ecosystem, how to access this data, either from the public institutions or from the private institutions, or like Sheetal said, so what constitutes the health data? So what is that can be shared? What is that can be shared only with conditions, or what is that which cannot be shared at all? So all these things had to be delineated, and that is why the task force, the ministry has constituted. So that plays a crucial role, and then we are waiting for the outcome of that committee's report.
Mr. Chandrasekhar, someone's asked to have more details on the Department of Health Research MOH, Working Committee on Ethics. Do you have any more details about this initiative that can be shared?
No, the ethics related policy maker is the DHR or ICMR. So I think ICMR would be the right agency to address these issues. As far as we are concerned, so whatever the ethics are, so they are part of the good clinical practices, so which we have made mandatory for any, say, manufacturer or any developer also. They need to comply with all the requirements of the GCP. So that's all. So as far as the regulator is concerned, as on date, it is the only thing that needs to be followed.
Understood. Thanks for the clarification. One pertinent question that does come up with respect to more input for developers is around what would be the quickest and most comprehensive way of establishing benchmarks for clinical efficacy with respect to AI. We've discussed the benchmarking process a little, but can you give more input on what a roadmap or something like that would look like for a manufacturer or a developer?
The most important for benchmarking is having a reference data set. So you first need to design and develop AI tool, and then benchmark it with the reference data set. So where this reference data set comes up, so that is the challenge now we have been discussing throughout this. So the reference data set might be from the public institutions or the private institutions, and what should be the size of this data set that is needed for benchmarking. So that is most important, and this size also depends upon the quality of the AI tool or the algorithm that is under development. So these are the issues. So as far as the accessing of the data set is reference data set is concerned, so we it is the say what I can say is that there should be some experts panel which need to go through the how the reference data has how the data has been created, whether it has been evaluated properly, and then what is the quality of the reference data set. So all these things are required. So then only you can say something.
It's important to distinguish between benchmarking performance and efficacy. So for example, if you were to diagnose diabetic retinopathy on an AI tool, that's performance, exactly a reference data set, exactly as Chandra said, is all that is required. If your efficacy measure was prevention of diabetic retinopathy induced blindness, no AI tool can do it by itself. So that's a more governmental policy decision of introduction of AI tools at government's cost into the periphery. And sometimes the two get a bit mixed up from time to time. So efficacy is about outcomes. And AIs typically don't necessarily, are not sufficient. They may be necessary, but certainly are not sufficient to lead to outcome changes.
Yes. Moving to a question from the audience for Sheetal. This is around security issues. AI-based healthcare equipment can have data and surveillance-based security issues, as most equipment are imported. Have we developed any safeguards for these AI-based tools?
No, so again, my answer remains the same, the standard. I think this is the conundrum that we are in at the moment. So, and you know, so many questions coming up, really seeking clarity. It only underlines the urgency about really coming out with rules and policies that tell innovators more about data sharing or referencing or, you know, going for benchmarking, etc. So I would not, unfortunately, have a very enlightening answer for this at the moment, just because there is no answer at the moment.
I would agree with Sheetal. There are many questions to which we ourselves seek answers from time to time.
And a big part of this is the resolution between Disha and PDP, which is yet to be determined. So you can take a point on privacy maximization versus balancing for patient safety, but that needs to be a perspective that's taken based on context.
I would say that India should not blindly, here I would slightly disagree with Sheetal, that for all the world there can be only one general policy. I personally feel that the concept of public good and health as a public good itself, so even in a pandemic you can see individual health and individual health rights cannot always be separated from health as a public right. And therefore, data as a public health good is a concept that countries that face severe societal challenges must keep in mind before adopting something like GDPR or something like that blindly in its totality in India. The underlying ethics, the moral principles must remain constant all over the world. Whether they learn from us or we learn from them doesn't really matter. But the specifics of implementation must be context specific. And maybe I'm in agreement with Sheetal, for all I know.
No, I think the specifics have to be worked out. But my main point was that the principles, moral and ethical guidelines cannot be different.
I agree.
Thank you. I think we're going to take this last question and we're going to make it topical. We've managed to not bring up COVID through the entirety of this webinar. So one question that's addressed to Dr. Agrawal is, how has AI helped India in its fight against the current COVID pandemic?
India, so far, not very much. Demonstration in the world that AI can help, absolutely. If you look at what China did in Wuhan, starting from surveillance strategies to even delivery of things to home strategies to the suite of apps it built to give people information in terms of who might be infected near them, Arogya Setu's proximity infection indicator is the closest to that right now, to automated interpretation of genomic as well as radiology tests, virtually being done in the scale of thousands without going through any immediate regulatory pathway, is an example of how when things are integrated and done well, they work. But it also reminds that other countries, which were not purely autocratic, also did a good job using AI in a slightly more, less invasive way. South Korea, Taiwan would be good examples of there. So the power of AI has been shown. We need to be careful that we don't use it as a Trojan horse. One must always worry that pandemics don't get used as a way to introduce for other purposes. And I'm very, very certain, knowing the history of humanity, that we must be careful about where this leads us. And we must understand that China has shown the power of AI, but we must also understand that use of AI must still be deliberated, discussed, and with appropriate regulations, morals, and ethics. And even if we use for a pandemic, we must know when will we stop using it. Any tool that we do in an emergency. And I'm very sure Sheetal will agree on this one.
Oh, completely.
Great, thank you, Mr. Agrawal. That was an incredible closing statement, which is to focus on the ethics and resolving for foundational principles before we move into allowing AI to first accelerate its way into a pandemic and then find its way into other aspects of public health as well. Those are all the questions that we're going to be taking to the audience. If you have any questions, you can obviously write to and engage with our panelists on social media or through email, or use ORF or IIC as a channel to do so. We hope you took away something from today's webinar. Thank you to the audience for being incredible participants in the discussion. And thank you to our esteemed panelists for giving so much input and adding so much nuance to the discussion around regulating AI and its specifically its privacy issues. Thank you.
Thank you all. Bye-bye.
Thank you.
Bye.